Thanks everyone for joining us for ethics this year. For our first ethics lecture of the academic year, we have Dr. Michael Puente, who's going to give a lecture for us regarding intellectual and developmental disabilities in the eye clinic. Dr. Michael Puente is an assistant professor of ophthalmology at the University of Colorado and Children's Hospital Colorado, where he serves as the Director of Medical Student Education. Dr. Puente completed his ophthalmology residency at Tulane University, followed by a fellowship in pediatric ophthalmology and adult strabismus at the University of Colorado. Dr. Puente currently serves as the president of the Colorado Society of Eye Physicians and Surgeons. He is a co-founder of the American Academy of Ophthalmology's LGBTQ+ community, and he serves as chair of APOS's advocacy committee. In 2021, Dr. Puente founded the University of Colorado's Pediatric Adult Transition Clinic, a comprehensive ophthalmology clinic specifically for patients with intellectual and developmental disabilities, and he's working to raise awareness and promote discussion of disparities in ophthalmology care for patients with disabilities. So I have a lot of fun facts about Dr. Puente from our residency together, but Dr. Puente is the proud dog dad to two Pomeranians, Brutus and Stella. He recently went on vacation to Pomerania, which is a real place on the coast of northern Poland.
Thank you all so much for having me. I'm really excited to be here and really excited to talk to you guys about something I'm really passionate about, and that's eye care for the very marginalized, vulnerable population of patients with intellectual and developmental disabilities. My one disclosure is that I am a consultant for the Global Down Syndrome Foundation, and they've provided me some research support. So I wanted to start off with a few patient stories from my clinic. Jess is a patient who is a 26-year-old male with Down syndrome who was seen in the resident clinic at the University of Colorado in summer 2020 for acute clouding of the left cornea. So could one of the residents tell me just right off the bat, when you hear someone with Down syndrome who has an acute cloudy cornea, what is that until proven otherwise? Eye drops until proven otherwise, yeah. So that patient was diagnosed with keratoconus in both eyes with eye drops in the left eye. Keratoconus happens in about a third of patients with Down syndrome. So the resident clinic correctly diagnosed the patient as having keratoconus, much worse in the left eye than the right. So at this point, what would be treatment goals if you have this patient in front of you? Big picture, what do you want to accomplish?
You want to try to get the cornea clear. So like starting off with say a hybrid products like that, just so you can get the sense of and then bridge your starting to do that.
How about more long term? There's something else that's really important that can anyone else think of? How about the other eye? Like if they got eye drops in one eye and they have keratoconus in the other eye, probably at high risk of getting eye drops in that other eye too. So this patient was followed annually in the resident clinic to monitor the keratoconus, and they acutely dealt with the eye drops in the left eye, but they just monitored the keratoconus in the other eye. Well, 4 years later, he got eye drops in that eye too. At which point he was referred to me in my clinic for adults with intellectual and developmental disabilities. But it was too late to do anything. They had recognized that this patient had keratoconus in the other eye that was at a milder stage 4 years ago, and the patient was not offered cross-linking. I think the only reason that they weren't offered cross-linking was because it's more challenging to cross-link a patient with intellectual and developmental disabilities. So I feel like this patient was allowed to go blind in the second eye just because of their disability. There's another patient I saw recently, also with Down syndrome. This is Aaron. He's nonverbal. A lot of patients with Down syndrome have autism and maybe nonverbal or minimally verbal. He had worn glasses as a child, but he hadn't had an eye exam in over 20 years. His parents said that since he couldn't communicate, they figured it wouldn't be possible to do an eye exam. But that's not true. He came to my clinic and I found he was a -8 in both eyes. Imagine walking around the world as a -8 for 20 years because people didn't think that it was possible to do an eye exam. And then there are similar patients who do get eye exams. Jonathan had cerebral palsy, a seizure disorder. He was also nonverbal, and he had all of those pretty much annual eye exams at our institution. And there was no mention of refractive error in any of the notes from any of his annual eye exams. He couldn't read the Snellen eye chart. They just said that he had fix and follow vision, but no one bothered to measure what his refractive error. Maybe he had fix and follow vision, but he was a -8 like the last patient. That's not the standard of care. How about Faith? She was a 26-year-old nonverbal woman with Smith-Lemli-Opitz syndrome, and she got a red eye in April 2023, but her mom said that they called multiple practices in the Denver area, private ophthalmology and optometry practices, saying that they had a challenging to examine young woman that had a red eye, and they kept saying, no, we really just can't take care of a patient like her in our clinic. We don't have the setup for someone like her. And a couple months later, she found her way to me, and she had a perforated neurotrophic corneal ulcer that I assume was allowed to just fester and get to that point because multiple practices in our area said that they just couldn't take care of someone like her. And then it got even worse. She ended up developing sympathetic ophthalmia in the other eye. Another patient that came to mind was Daryl. He's a 52-year-old nonverbal man with severe autism and intellectual disability. He had self-injurious tendencies and a very active lifestyle. His parents told me that they had to like nail all the furniture onto the floor because he just loved mountain climbing around the living room, and he'd fall and hit his head all the time. And he gave himself a traumatic funnel retinal detachment in his left eye, became thicycle, ended up having to be enucleated. But then he also gave himself a total cataract in the other eye, a traumatic cataract. And he went to an outside ophthalmologist who said they were unable to operate on Daryl because his note said they lacked the setup for such a patient. So that begs the question of what is the setup for such a patient? Why are so many of these patients not getting the care that they need? Even if they do see an ophthalmologist, why are so many patients not getting the standard of care? There are a lot of challenges in examining these patients. Can anyone think of any challenges that you guys have faced in trying to take care of patients with intellectual or developmental disability? Yeah, they don't always like to sit still. Sometimes you have to examine them sitting on the floor or in another chair. Yeah, they don't always like to sit still. Is that the only problem?
Several, some that come to mind for me is trying to figure out the level of engagement you'll be allowed with the patient, starting from across the room, inching forward, perhaps using a light from 5 feet away initially, and in many ways, I don't know what level of exam I'll be able to get in the end. Just based on patients, oftentimes technicians, I'll actually ask them to perhaps just room the patient initially, so that if we do only have 2 minutes with them, it's time that I can spend.
Yeah, you have to kind of build trust with them. Oftentimes that takes a lot of time. You can't just throw them straight in the slit lamp all the time. What else?
I think sometimes the parents or guardians' expectation of how the visit will go might differ from like what you're looking to get out of the exam, and so bridging the gap needs to be challenging as well.
Yeah, definitely. I have a lot of parents who are really upset with me because they just want to go straight to the operating room for an exam under anesthesia. That's what they say. Everyone else is always done. They don't understand why they have to come to clinic when they could just go to the operating room. And sometimes it takes me a while to win those parents over. And oftentimes these families have had medical trauma in the past that people really didn't take their loved ones seriously, felt like they neglected them, didn't listen to them, didn't provide the standard of care. And so when you're first meeting them, they're often nervous that you're going to be one of those people that's going to be disrespectful to them and their loved one, and you have to win them over. Any other challenges?
also a lot of lights and sounds and different things that could be very overwhelming.
Yeah, definitely. So you guys hit on a lot of the things that I put here, but a lot of our exam can be very scary and uncomfortable for patients with IDD or intellectual developmental disability. The bright lights, like you mentioned, having so many objects close to your face, the eye drops that we put in can be very traumatic. Just the strangers can also be very traumatic. And then how about measuring visual acuity in these patients? In my clinic a couple weeks ago, I had a patient I counted over a dozen exams in our institution before where their vision was listed as light perception at several visits, hand motion at some visits, fix and fall at some visits. We got them to 20/70, just using some more creative eye charts. Sure, they didn't know the alphabet. Sure, they were nonverbal, but they could still match with like Allen pictures and things that we use in the pediatric eye clinic all the time. And someone, multiple people, had written that their vision was light perception when they were 20/70. So we have to be more creative in how we measure visual acuity. You can't necessarily use the same technique that you would use for 99% of your other patients. And then our specialty relies a lot on testing and objective measurements. And sometimes those measurements can be challenging to get. Challenging, but not impossible. Sometimes you have to be creative. We mentioned that people with Down syndrome have about a 33% risk of keratoconus. So anytime I meet a patient with Down syndrome for the first time, I immediately order a Penacam, just no questions asked. And I had a patient recently who came to me, I ordered the Penacam, and then I went to see the results. And there was a note from the technician saying, unable to obtain Penacam because her wheelchair didn't fit at the machine. So can you guys think of a way that you could get the Penacam in a situation like that? Exactly. So that's all we had to do. Just pick her up out of her wheelchair that didn't fit, put her in a different chair. But the technicians that were doing our diagnostics that day just didn't give the patient a chance. You have to be a little bit more flexible. And we oftentimes can get the imaging that we want. And then these patients can be difficult to refract. They're oftentimes not going to do great at the 4-opter with a subjective refraction, but that doesn't mean you can't refract them. Like I'm a pediatric ophthalmologist. If I said that I couldn't refract a patient who couldn't cooperate with a Snellen eye chart and subjective refraction, I'd be fired like that. Like there are plenty of ways that you can refract a patient without them being able to cooperate at the 4-opter. And it's not fair for us to not offer that to our patients. But then I think it also comes down to a lack of specific training during residencies and in technician training for how to care for people with IDD. There are lots of tips and tricks and techniques for how to get a more effective exam on these patients. And the tips and tricks I've figured out are things I've had to figure out on my own because there's just very limited training available. So these patients can be more challenging to examine in the eye clinic, but that doesn't make it any less important. People with intellectual disability have very high rates of vision problems. And the severity of intellectual disability oftentimes correlates with the severity of visual impairment. For the more high-functioning patients with IDD, like Special Olympians, about 40% of them have treatable vision problems. And then from some older studies from times when we used to institutionalize people with IDD, kind of separate them from society and put them in just some home where they could be kept together. Studies of the people with severe IDD found that they consistently had high rates of blindness and severe visual impairment. So it's really important that these patients get care. But at the same time, it can be harder for us to give them that care. Having low vision in a patient with IDD can really hurt their quality of life. There's a concept called the Lowenfeld losses that describes just big picture ways that low vision can affect someone's quality of life. And there are 3 main parts of that. So one is the loss of range and variety of experiences. So just imagine, for those of you who have kids, you might like taking them to the zoo to go see the animals there. And that's just a fun excursion. And that's something that a lot of my patients with IDD really enjoy as well. But if you're a -8 myope who hasn't been offered an eye exam in 20 years, how are you going to enjoy the zoo if you can't see past your wrist clearly? That's something that limits the richness of life that they can have if they're not being offered the care that they need. Similarly, imagine like going to a park for a picnic with your family, and let's say that it's crowded and you get separated from them. If you can't see very well, then that's going to be a really scary environment to navigate, and you might be so traumatized from that that you don't want to ever go on a picnic again. You don't ever want to go to the park again. This low vision can limit the richness of experiences that they can have. And then loss of ability to move around. In Colorado, here in Utah, we have lots of beautiful places to hike. That's Hawaii there, but just imagine someone with low vision, they can't go out and enjoy the beautiful environment that we have around us in both of our places here. And then loss of environmental control and self within it. So I've seen plenty of doctors' desks that look something like that. Imagine asking someone with low vision to go find a pencil there. They might know exactly what a pencil looks like, but when you have a really cluttered environment with a whole lot of distractors, it's harder to function. So these patients, sure, maybe they can't all be employed, maybe they can't all have the same experiences that we have, but their lives still matter, and the low vision deeply impacts them. So you've probably all heard that there's a connection between low vision and dementia. This was a study done in Korea where they looked at risk of dementia in Koreans over 40 years old. And the blue line is people who had normal vision, green is people with mild visual impairment, red and black were people with moderate and severe visual impairment. And the risk of dementia over the course of 7 years was substantially higher as vision got worse. And there have been plenty of other studies that have found similar conclusions. We know that vision problems can exacerbate cognitive decline. Cataract surgery has been shown to reduce the risk of dementia and cognitive impairment. We know that treating vision problems in adults can help to preserve their cognitive function. So in patients who already have intellectual developmental disability at baseline, if we're throwing on top of that visual impairment, in particular treatable, correctable visual impairment, then it's going to make a lot of those other problems worse. So getting back to Down syndrome, I wanted to talk about just some of the specific things that we can find on an eye exam in a big population of patients with IDD. So can you guys name some things that you should be looking for when you have a patient with Down syndrome come into your clinic? Can we name like 10 things that are really common on an eye exam in people with Down syndrome? Strabismus, yeah, that's present in about 50% of people with Down syndrome. There are hundreds of thousands of people with Down syndrome in this country. They come into your eye clinic, and there are so many things that are very common in their eyes. So it's really important that we have to know what to look for, or we're not going to be able to give them the exam they need. Refractive error. Almost everyone with Down syndrome needs glasses. Keratoconus is present in about a third of them. They get very early cataracts. Amblyopia can come from any number of other things that we find in their eyes in childhood, yeah. They have a higher rate of optic disc drusen and other optic nerve abnormalities.
LDO.
NLDO is super common in people with Down syndrome. Great, well, that's a good start. So trisomy 21 is the most common chromosomal disorder in the world. The CDC estimates that about 1 in 700 live births in the United States are a baby with Down syndrome, and that's up from 1 in 1,087 in 1990. And we have no reliable estimate of the total population with Down syndrome in the US, but it's thought to be at least a couple 100,000. Does anyone know what the life expectancy was for someone with Down syndrome in the year 1900? Anyone guess? 20? Go down. It's 9. How about by 1949? 12. How about 1983? Yeah, we got up to 25 there. How about pretty much now? No, it's actually up to, like, depending on the study, anywhere from like 55 to 60. So Down syndrome, it affects the eyes in so many ways, but it affects every other organ system as well. They have really high rates of congenital cardiac anomalies that in the past were often not treated. The medical field would often tell families, your child has this congenital heart problem, it's going to be fatal. We could do this big invasive surgery to fix it, but they would have a horrible quality of life. They have Down syndrome. Let's just put them out of their misery and not do this big invasive heart surgery. Let's just keep them comfortable. And that was the mantra of medicine for a long time. For many decades, we just denied care to patients with Down syndrome. But that has changed in the most recent decades. And now they're living lives almost as long as the general population. So Down syndrome is no longer just a pediatric disease. Pediatric ophthalmologists tend to have a lot more expertise in Down syndrome than adult ophthalmologists. There's so much research out there on ophthalmologic findings in children with Down syndrome, but then once you get to the adult age group, the research largely stops. And that's a big disparity in our knowledge that I think has some ethical implications, because these patients are going to be in every one of your clinics. So let's just run through some of the things that you should be looking for. Like we mentioned, refractive error is really common. About 80% of children with Down syndrome need glasses, and that number just goes up as they get older. They have similar level of refractive error before 1 year of age compared to their peers, but children aren't born with planosphere eyes. They have a high level of refractive error in the first year of life. And then the eyes go through a process of emmetropization. But the eyes of children with Down syndrome don't emmetropize the same way. At primary school age, a little over a third of kids with Down syndrome have astigmatism. And it's rarely oblique astigmatism when they're about a year old, but by the time they're teenagers, 45% of the astigmatism in people with Down syndrome is oblique. So their eyes just grow differently into a different shape. And then also regarding glasses, they have really high rates of hypoaccommodation. Depending on the study, anywhere from 80 to 100% of people with Down syndrome have impaired accommodation. So I prescribe bifocals for most of my pediatric patients with Down syndrome and pretty much all of my adults with Down syndrome. We don't quite know why. There are two main theories. It could be like a presbyopia-like mechanism where there's some mechanical limitations to the accommodation of the lens, or it could also be something neurological. They have neurological differences that lead to their intellectual developmental disability. And it's thought there may also be some neurological differences in the signaling pathway that's needed for accommodation. And then strabismus, like we mentioned, about 50% of people with Down syndrome have strabismus. Typically, it's esotropia rather than exotropia. And we've found that it is correctable. I've had many patients with Down syndrome come to me in my clinic for adults with intellectual disability with congenital esotropia, huge angle, that had never been offered treatment. And so I'm doing strabismus surgery on 20-something-year-olds, 30-something-year-olds, 40-something-year-olds who have had something that's been treatable for decades, but no one offered to treat it. And then they often have nystagmus as well. About a third of people with Down syndrome have nystagmus. So when you see a patient with Down syndrome in your clinic and they have nystagmus, you don't have to order an MRI and do a big workup unless there's something else neurological going on that's concerning. That's something that's super, super common. And there have been studies that find that the people with Down syndrome who have nystagmus, they have worse vision than their peers with Down syndrome who don't have nystagmus. And oftentimes it leads to ocular torticollis. There was a study at the University of Iowa where they looked at every patient they'd seen with Down syndrome in their clinic over the course of 20 years, and about a quarter of them had torticollis, which they attributed to strabismus and nystagmus in many of those patients. We mentioned nasolacrimal duct obstruction. That's something that's present in over a third of children with Down syndrome, way higher than the population at large. It's usually bilateral. And what's the most common cause of nasolacrimal duct obstruction in the general population? What's the actual physical problem? Yeah, an imperfect valve of Hasner is the most common cause in the general population, but not in kids with Down syndrome. In kids with Down syndrome, it's more likely due to bony obstruction, where there just isn't kind of a lumen there, or canalicular atresia, or an anteriorly displaced inferior turbinate that's blocking the drainage there. So it's more challenging to fix. But they should be offered surgery, because I have patients, again, in their 20s who've had congenital nasolacrimal duct obstruction. I had a patient recently who just moved from California. She'd never seen an ophthalmologist before, just optometrists, and had never been even mentioned that there was a treatment for this constant tearing, the constant eyelashes being crusted shut in the mornings every single day of her life for 20 years. She was denied surgery, and it's something that's fixable. It is more challenging. We generally have to do stenting or balloon dacryoplasty rather than just popping open the membrane. But even when we do that, sometimes we end up needing to do a DCR. It's more challenging, but we can fix it. And this is really important for their quality of life. We just have to offer it to them. And then their eyelids oftentimes are different from other people's. They have upslanting palpebral fissures. They have epicanthal folds. They very commonly have trichiasis and dystichiasis. Something I haven't seen published before, but I'm working on publishing myself, is I commonly notice that the temporalmost lashes of the upper lids grow back into the fornix. I see that very commonly in people with Down syndrome. It's just 1 or 2 lashes, and sometimes they're really long and they go all the way into the fornix. I see that very commonly. So it's become something that I just routinely put in my Down syndrome workup. And just imagine having a big lash embedded in your fornix for years. And then similarly, they have high rates of entropia and floppy lids. And we mentioned cataracts. They have really high rates of congenital cataracts. It's about 300 times the risk of the population at large. Basically, about 1 out of every 50 babies with Down syndrome is born with a cataract. And so they make up a big share of the pediatric cataract surgeries done at Children's Hospital. There was a recent study at the Children's Hospital in Dublin where they were just describing the patients they operated on in cataract surgery, and almost 10% of those kids had Down syndrome. And 10% of the children in Dublin do not have Down syndrome. They're just very overrepresented. It's something that's really common. But even for the 49 out of 50 babies with Down syndrome who aren't born with a cataract, they're likely to get a cataract not too much later. So people with Down syndrome develop cataracts at a much earlier age than the general population. They often need cataract surgery as early as their 20s or up to 40 years old. They commonly need cataract surgery around the same time as their parents do. And do you guys know what's the classic type of cataract that we see in people with Down syndrome? I don't think I've ever seen a PSC in someone with Down syndrome. That's a hint. Cerulean or blue dot cataract. This tends to start, I start seeing these little blue specks in there, usually around like 7 or 8 years old. And then they become more and more abundant. They become more confluent. It's usually not visually significant at first, but eventually these all kind of meld together and they can get a visually significant cataract at a much earlier age than the population at large. I kind of use this as a surrogate marker when I'm reading a clinic note from a patient who's seen an ophthalmologist or optometrist before, and they're in their teens or their 20s, and they say lens clear. I'm always suspicious when I read that because it's rarely clear. And when I put them at the slit lamp and I see that it's just full of this like snow globe-like appearance of the blue dots and the cerulean cataract, that tells me that wherever they had that last eye exam, they really didn't take a close look. So take a close look. And then we talked about keratoconus. That's something that's present in about 1/3 of people with Down syndrome. It typically develops in their childhood or teenage years, but then it keeps getting worse over the course of young adulthood. I had a patient just yesterday, 38 years old with Down syndrome, who developed an acute cloudy cornea of his right eye. Saw an optometrist in Colorado Springs, and the optometrist referred the patient to the University of Colorado. They placed a neuro-ophthalmology referral because the patient has intellectual disabilities. So they thought that was the right place for this patient with an acute cloudy cornea. And the neuro-ophthalmology team said that is not the appropriate place. And they messaged me. And I was on vacation for a couple of weeks. So I got them into one of our trainee clinics where they correctly diagnosed that there was high drops of one eye, but then they put that the other cornea was clear and normal. And I was skeptical again, because I've only seen 2 patients with Down syndrome and keratoconus where it was unilateral. It's almost always bilateral. So I had them come back to my clinic yesterday, and there was very big scarring in the other eye, positive Munson sign, but the trainees that saw them while I was out didn't take a close look. So it's something that we have to be looking for when you have a young person with Down syndrome in your clinic, about a 1/3 chance that they have keratoconus. You can get corneal topography in these patients. It might be more challenging. You might think it's not possible. We did a study at Children's Hospital Colorado where we ordered a Penacam automatically on every patient with Down syndrome, and we were able to get a reliable scan in about 3/4 of the patients in at least one eye. It can be done. Just give them a chance. And if it can't be done, if they can't cooperate with it, what are some other ways that you could look for signs of keratoconus?
Is there being like flexes on retinopathy?
Yeah, do retinoscopy and just see if it's a very uniform bar moving across in all directions. It's probably not keratoconus. But if you see that there's the scissoring there, that's probably keratoconus. Or just getting a good look at the cornea, just with the muscle light or the slit lamp. You have to look. And if you find that they have keratoconus and you're worried it's progressive, do something about it. I sadly have seen way too many patients who were diagnosed with keratoconus after they got high drops in one eye, diagnosed with keratoconus in the other eye, and no one offered them cross-linking. That's not the standard of care. So we recommend that you screen any patient with Down syndrome from about puberty or so onto the early 30s, because the latest I've seen someone get high drops with Down syndrome is 40 years old. So keratoconus needs to be identified and treated. Out of curiosity, are you guys able to do cross-linking under general anesthesia here?
We have any cornea specialists here, like this question has come up, and I'm not familiar as a retina specialist with what exactly like the criteria are for when to do cross-linking. Why they said no, maybe it was too advanced already. Or maybe because they can't do it under general, I don't know.
So it can be done, but it's not done often and probably not done often.
Yeah, we've cross-linked over 200 patients with intellectual disability at Children's Hospital Colorado. And in speaking to people from other institutions, we're only aware of 4, maybe 5 other places where that's offered, because we hear that there are a lot of barriers.
But the insurance often won't cover that. It's not inexpensive. How do you handle that? Because often we're talking families who, once you give them a price tag, that's pay for that.
Right. So we instituted a charity program at Children's Hospital Colorado, where we showed the CEO of the hospital pictures of high drop size from our clinic. And the photos were so disturbing that the CEO said, "I'll give you whatever you want," basically. And we came up with a program.
Guilt.
It's a useful tool sometimes.
Can be very powerful.
Yeah. But for patients who have private insurance, it tends to pay really well. And we were expecting that we were going to take a big hit, but we found that the patients with private insurance,
Medicaid pays for it in Colorado. Each state's a little different.
we lobbied for it, and now we believe we're the only state in the country where Medicaid covers it. But that's
Many of these kids are Medicaid, and that's
right. About 50% of our patients that we've cross-linked have Medicaid, and we convinced the state Medicaid office that this was a priority, that it was cheaper than having a blind person or cheaper than a corneal transplant and all that care. A recent change is, do you know if your pharmacy here is enrolled in 340B pricing?
Oh, yes.
So Glaukos now offers Photrexa kits for 1 penny. to institutions that purchase it through 340B pricing. That started a few months ago. And so we just a few weeks ago purchased 10 vials of Photrexa, and it cost us 10 cents with $50 shipping for the whole set. So $50.10 was what we were charged. And that's not just for patients with Medicaid. They sell it to us just for any patient we cross-link at our 340B institution. So I think where there's a will, there's a way. It takes a lot of work to get it set up, and it may not be the most lucrative thing that you guys do, but there's a big population of patients that really need this treatment, and it's an ethical issue if we aren't offering it to them when we're offering it to other patients. So the system is not set up to make it easy for us, but it's something that I think we need to think about and we need to prioritize, because a lot of these patients are going blind despite having a treatment that we offer to many other patients.
I think one other logistical problem is there a laser at Mid Valley where there's no operating room?
Yes, Amy answered back that cross-linking is only done in the minor room at Mid Valley. Topical only, no IV sedation or certain general.
There's no OR there.
It's just a minor room.
So where do you guys do your cases under general anesthesia?
Well, for the younger children, that would be a primary children's, which is not part of the university system, part of IHC. IHC, let's just say it's a not-for-profit, but margin is a very, very important part. But there is a foundation there, I think that getting a grant or something like this from them is doable. So I think it's something we definitely need to pursue.
Yeah, I actually have a grant from the Global Down Syndrome Foundation. We've been trying to find a hospital to take just a free set of like the machines that are used for cross-linking, and we've been having trouble finding a hospital willing to do it because of the insurance issues for Medicaid. But there are grants out there. There are ways that it can be done. It just has to be a team effort and a team priority, because a lot of these patients are slipping through the cracks. They come to our clinic, and I've seen us neglect them at the University of Colorado. It's pretty tragic. I set up a meeting with some of our department leadership a couple weeks ago after I saw that first patient I mentioned who was diagnosed with high drops in one eye in 2020 and then was just followed annually and allowed to go blind in the other eye. And then he was referred to me once it was too late to do anything. That really bothered me. So I came up with a list of patients like that. And it's over 20 patients with intellectual disability who'd been denied cross-linking, not because of insurance issues, but just because of their intellectual disability, that they couldn't do it awake. And so we're working on systems changes to allow that to be offered to them. So this is a really important issue for patients with Down syndrome, but not just Down syndrome. Keratoconus, for reasons we don't understand, is really common in the population with intellectual and developmental disability at large. Patients with autism and other syndromes that cause IDD have really high rates of keratoconus.
For sure, it's eye rubbing.
I think so.
The mechanical theory correlates. It's been hard to tie down, but I've just seen enough families where clearly there's often a genetic susceptibility, but the only one who gets it in the family are those everyone said was rubbing their eyes all the time.
Mm-hmm.
And if you look and see, rubbing eyes for those is a common problem, and it's very hard to try to tell them not to do it.
Right.
I understand that the phosphates in the retina is created when you rub really vigorously. We've all had that experience, which is essentially the retina. Because when you rub hard, you cut off all flow of the retina, and as the blood comes back and as it recovers, there's these interesting phosphates, and so they do that for that stimulation. That's what I've heard people talk about.
Right.
And so I think that's why we see that so commonly. And you raise a great point that, for us, often it's just frustrating. It's IHC. There's always a battle between the university and IHC. It's the children's hospital. But we do know it's the most profitable hospital. There's a lot of money we've made, and they do have a foundation, and I think too often we assume, just because IHC is not very flexible in any of this, primary children's can be. So we need to run that, because they do have a foundation with substantial funding that often, this is the kind of thing where we take it from it. Just somebody, we just need to make the decision and go forward. So we appreciate hearing about that.
Where there's a will, there's a way. So talking about some other things that we need to look for in people with Down syndrome, their retinas. So about 60% of people with Down syndrome have some degree of foveal hypoplasia. And then what are some of the most common causes of retinal vision loss in adults in the general population? Macular degeneration, and what's another really big one? Diabetic retinopathy. Yeah, so there's only one published study that evaluates the risk of diabetic retinopathy in patients with Down syndrome. And what they did was they just took 9 diabetic patients with Down syndrome and they looked at their eyes one time. And they saw one of them look like they had diabetic retinopathy. So this study concluded that all people with diabetes and Down syndrome have a lower risk of diabetic retinopathy than the population at large, just by looking at 9 people's eyes one time. No control group, no A1C, nothing like that. And yet this paper's been cited 46 times because this is the only paper that talks about diabetic retinopathy in people with Down syndrome, even though diabetes is pretty common in people with Down syndrome, and now they're living into their 50s, 60s, 70s. So this is a big gap in our research. Similarly with retina. With macular degeneration, there's been not a single study published on macular degeneration in people with Down syndrome. Not that they don't have it, but just that we haven't cared as a field to study it. I've diagnosed someone with geographic atrophy as young as 41. I recently, drawing a blank, sleep deprived. The IRIS registry from AAO, I got data from them on every retinal diagnosis and every patient with Down syndrome in their database. And we found over 800 patients with macular degeneration and Down syndrome. And yet not a single one of those has ever been described in the literature. So these patients have the same diseases that the general population does, but we as a field have not done enough to learn about how it affects them and how treatment may differ for them.
Increased risk of retinal detachment.
They do have an increased risk of retinal detachment.
Has been documented.
Yes. Yeah, they have they often have high myopia. They often have self-injurious behavior. They have high rates of retinal detachment, for sure. And then optic nerve anomalies are very common. Optic nerve hypoplasia, tilted discs, optic disc elevation, peripapillary atrophy, optic disc crescents. Lots of patients have just tons and tons of vessels coming off of their optic nerves. And we've documented that these differences exist, but we don't really know their clinical significance. There hasn't been enough research into that. How about glaucoma? Can you guys guess how many patients were involved in the only ever study on glaucoma in people with Down syndrome?
I'm guessing not very many.
3. And that's it. That's ridiculous. Yeah, a little bit. But they concluded from this study that people with Down syndrome have a higher risk of glaucoma than the population at large, and that has been cited many times. That's ridiculous. They might have a higher risk of glaucoma than the population at large, but a study of a case series of 3 patients does not prove that. And also, the way that they diagnosed glaucoma was just looking at their optic nerves. They had 2 glaucoma specialists each look at their optic nerves, and they said, oh, those look glaucomatous to me. But as we said in the last slide, they have different looking nerves. So we have a huge gap in our knowledge here, and we've got a lot we need to do to rectify that. Moving back from the optic nerve, it's thought that there's high rates of cortical visual impairment as well, that Down syndrome is associated with impaired cortical development in childhood, and then also accelerated cortical atrophy in adulthood. So we hypothesize that differences in their visual cortex are largely responsible for some of the vision problems that people with Down syndrome have. It's very rare that I get a patient with Down syndrome to see the 20/20 line, even if their eyes look perfectly healthy and they have like none of these other things we were talking about, they still just get stuck at like 20/40. And it's thought that that cortical visual impairment is an important part of that. So putting all of this together, visual acuity in children with Down syndrome is often not great. 94% of children with Down syndrome have below average vision. 79% of them have visual acuity that's more than 2 standard deviations worse than average for kids their age. And then it just gets worse in adulthood. 46% of adults with Down syndrome in their 50s have visual impairment. And then in the next decade, it goes up to almost all of them. 85% of adults with Down syndrome older than 60 have visual impairment. So people with Down syndrome and other causes of IDD, they need ophthalmology care, they need research. But as we saw in the cases I shared at the beginning, a lot of these patients are not getting the care they need. There are huge disparities in eye care for patients with intellectual and developmental disabilities. And I don't think it's something that we talk about enough. When we talk about DEI and health disparities in ophthalmology, I think we tend to focus on the disparities that we see in racial and ethnic groups and socioeconomic status. But this is a huge population of patients that have really high rates of ophthalmological disease that is often treatable. And even when they come to our clinics, oftentimes they're not getting the care they need. So we can do better. One place that's tried to do better is Emory. In 2014, they set up an eye clinic for patients of all ages with intellectual or developmental disabilities. And every patient was seen by a pediatric ophthalmologist, Dr. Cheryl Menaker. And she published just a report of how her clinic went the first few years. They had 281 visits by 178 patients, and majority were pediatric, but about a third were adults. 67% were nonverbal. The most common non-ocular diagnoses were autism, Down syndrome, and cerebral palsy. But looking at what they found, 79% of patients had something wrong with their eyes, some sort of pathology or significant refractive error. And 71% of them had a treatable ocular condition. And when they came to her, 56% of those treatable conditions were newly diagnosed. The majority of those patients had been seen elsewhere before, but didn't get as thorough of an exam. She found that she was able to get a cycloplegic refraction in 94% of those patients, which I think is a higher rate than these patients are getting on average across ophthalmology and across optometry. She found that she was able to get a dilated fundus exam in 98% of those patients and a slit lamp exam in 99% of those patients. I've read so many notes that families bring with me from prior eye exams where they said, unable on the slit lamp exam and the dilated exam and the refraction. You are able. There's just challenges and differences in the exam, but if you prioritize it and make time and also have the built expertise in how to do it, you oftentimes can get a good exam on these patients so we can give them equitable care. So moving to my institution, this hospital up front, this beautiful building there is Children's Hospital Colorado. That's my main base of operations as a pediatric ophthalmologist. But our adult eye center is across the street, the Sue Anschutz Rogers Eye Center. And I set up a clinic at the Adult Eye Center in 2021, the Pediatric Adult Ophthalmology Transition Clinic. And our patients are seen, patients with IDD are seen there in the Adult Eye Clinic by me, a pediatric ophthalmologist, or one of my colleagues from Children's Hospital Colorado, who's a pediatric optometrist. And then we also have a dedicated ophthalmic technician who's with us every day. We have the clinic, Rasha Kailani El-Nadiwi, who is so passionate about taking care of these patients and training the other technicians at our eye center to be able to take care of these patients. So when they go to the retina clinic, when they go to the glaucoma clinic or the oculoplastics clinic, they don't just write light perception vision, that they can get a thorough workup. And we get referrals from all sorts of sources. We have patients who age out of Children's Hospital Colorado and have nowhere else to go. And then we also have patients from our adult ophthalmology and optometry colleagues. If they said that they just really couldn't get a good exam, they send them to our pediatric team to see if we have better luck. And then we also set up a policy where any patient who's referred to the University of Colorado from out in the community for an EUA automatically gets scheduled in our clinic first. They don't go to the EUA until we say they need it. And we found that over 90% of the time, they don't need it. We were able to get all the information we needed in clinic. That saves a ton of time, a ton of cost, reduces the risk to the patient that they don't have to be sedated with a tube down their throat just for an eye exam. That's
And you
one of the-
often get a better exam.
and we often get a better
Because
exam
you've
too, I
got
think.
cooperation, when they're totally sick, you have no idea how they're responding. Or what.
Right. So that's something that we're really proud of, that has worked really well. The parents aren't always amenable to it at first. They're like always gone under anesthesia, like they can't cooperate in clinic. And then when we give them a chance, they often can. And then the word's gotten out to PCPs. We're now a lot of PCPs who take care of patients with IDD have found out about our clinic, and they're sending patients to us. So what we offer is comprehensive eye care for patients with special needs. And we offer a pediatric approach in an adult setting, because the techniques that I use to examine a 2-year-old or an autistic teenager work just as well in this population, I find. And it's a small clinic. I don't schedule 50 patients a day. We have limited patient slots to allow the patients all the time that they need. We offer retinoscopic refractions. We have an on-site social worker who's with us every day to help address other needs that these families have. We offer cataract surgery. We offer YAG capsulotomy, corneal collagen cross-linking under general anesthesia. But our wait list is now over 7 months long. And every time that we expand the clinic, the wait list gets right back up. And I feel guilty about that. I keep trying to add more slots, and I'm staying until like 6 or 7 o'clock in the evening, and then the wait list just keeps getting longer. There's an enormous need. And so it's been challenging. We found several big challenges. One of the biggest ones has been scheduling these patients for surgery. So our ambulatory surgical center has an anesthesia team, and they set the eligibility criteria to be operated on in our ASC. And they say that if a patient has IDD, they just cannot be operated on at our ambulatory surgical center, that they might have longer recovery. It might be harder to put in the IV. They expressed safety concerns and staffing concerns. And so they say, we cannot operate on them at the Sue Ann Schutz Rogers Eye Center. You have to send them somewhere else. So we have to operate on them at the UC Health inpatient hospital, where our department doesn't have block time because we have our own ASC. So UC Health said, you guys don't need block time. You have your own ORs. And so we've had patients who've been waiting over a year to get surgery. We have a huge wait list, a backlog, not just of patients with IDD, but of patients who just are high risk for anesthesia and can't be operated on in the ASC. And I think it's a violation of the Americans with Disabilities Act to say that a patient, if they didn't have this medical problem, medical comorbidity, could get their cataract out in a few weeks, but because of this medical comorbidity, they have to wait a year. There's some medical legal risk there and ethical issues in delaying their care. And this has been a big frustration for me and my team, that we're struggling to get the patients in a timely manner because of some systems issues. And then even when we are able to get them scheduled for surgery, who should do the surgery? Like maybe I'm the one that's able to get the thorough exam as a pediatric ophthalmologist, but I haven't used phaco since 2019. I take out pediatric cataracts and they're just so soft, you just slurp them right out. You don't have to break them apart. But these are often really advanced cataracts. And it's been hard to find colleagues in my department who are excited about doing these really complicated cases. And then providing a safe post-op environment in the PACU and also at home. Like, these patients are high risk of rubbing at their eye after you did intraocular surgery. We've done I've gotten orthopedic surgery to put plaster casts on some patients' elbows to keep it that they just can't rub their eye for a week or two. That was really hard to get ortho to agree to, but we do that at children's all the time. On the adult side, the orthopedic surgeons thought I was nuts, but I think sometimes we have to be creative that way. And then insurance has been a challenge for cross-linking, as we discussed. Demand greatly exceeds capacity. And then we also found crunching the numbers of the revenue I bring in my general pediatric ophthalmology clinic at Children's and the revenue I bring in at this transition clinic. I bring in about 35% of the revenue I do at Children's. That's not insignificant. And the latest round that we had to expand my clinic because the wait list got so long, I spoke with the chair of my department and he agreed to make me whole, that it's a service to the rest of the department that these patients are going to be seen in my clinic rather than being disrupting another really high volume clinic. It's a service to the community, but that's not very sustainable, not something that every place can emulate. Makes it harder for these patients to get care in private practice. But that's what we found needed to happen at our institution. So some big picture questions, it's these patients really need our care. Oftentimes they're not getting it. There are all sorts of challenges that make it harder for us to get their care. So, are these patients better served by pediatric ophthalmologists and optometrists, or should we get adult ophthalmologists and optometrists to feel more comfortable and skilled in examining these patients? I don't know. It's probably a mix of both. Should patients with IDD primarily be seen at academic centers? I don't know if that's the right approach either. I think it's something that that patients in any community should be able to get care at their local eye doctor. But there are plenty of obstacles to getting these patients into private practices. And then when we're doing cataract surgery or other surgery, should we use the same technique? Like imagine doing a YAG in clinic on a severely intellectually disabled, non-cooperative patient. You'd have to do the YAG under anesthesia. So should we maybe do like a primary posterior capsulotomy like we do on our congenital cataract? Should we do that in adults too? I don't know. That's never been discussed in the literature. And then how about what lens do we put in? Like what refraction should we aim for? Should we put a toric, multifocal? I don't know. That's never been discussed in the literature either. Should we be suturing our wounds to keep them from damaging their eyes in the post-op period? How about like, should we be routinely putting arm restraints, or is that something that we should be trying to avoid? I don't know. These are a lot of questions that I think our field needs to discuss and study. And then we mentioned that I can't see as many patients as I can in a typical clinic. I'm not generating quite as many surgeries as I do in my typical clinic. So how do we make caring for these patients financially sustainable? There might need to be some advocacy on a federal or state level to increase funding for eye care for these patients, to make it that it's not such a financial drain for the doctors that do this. But should academic centers subsidize doctors who take on this responsibility? That's what we did at my institution, but I don't know if that's the right model for other places. And then how do we get technicians to do better workups on these patients? And then equally importantly, how do we get residents to graduate feeling comfortable taking care of these patients? I know when I graduated from my residency, I didn't know how to take care of these patients. I feel like I wrote a lot of notes in residency that were basically the equivalent of eyes present bilaterally, come back in a year. And that's not good care, but I was never really taught how to do it better. So where do we go from here? I'm working to create an intellectual developmental disabilities work group within AAO because there are just so many questions and issues here that I think need to be discussed and addressed. I think it'd be great for residents to be required to have some training in caring for patients with disabilities. Same thing for technicians. There should be modules offered for them. And I'm working with some partners in the Global Down Syndrome Foundation to write guidelines for eye care for adults with Down syndrome. So in conclusion, these patients need our care. Many of these patients are slipping through the cracks, either by not getting care at all or by receiving less than the standard of care. So I think we need to seriously discuss and study barriers and solutions to providing equitable care for patients with IDD. I think we have an ethical imperative to do better. So thank you.